So the next session is to talk more about how innovation collides with clinical reality. Innovation has always led the practice of regional anesthesia forwards, but adoption sometimes outpaces evidence. So there are newer blocks, newer techniques, newer subspecialties where we apply regional anesthesia every day more and more. So this session critically examines the newer therapies available and the newer subspecialties where we are applying regional anesthesia. And the first talk is by my very dear friend Hesham, who I know him for a long time since his Cleveland clinic days. He has led the innovation in peripheral neuromodulation for a long time. So the first talk will be on past, present, and future of peripheral nerve stimulation. It's followed by applying regional anesthesia on uncommon anesthetic indications like urologic surgery and cardiac surgery. Hopefully it becomes more common. And also another important topic of managing chronic pain management in pregnancy later on by Jarna Shah. With no further ado, I'll let Raj
Welcome, Hesham.
Hey,
Great to
how are
have
you
you
doing,
here.
everybody? Thank you for having
so
me.
good to have you here. And I'm going to get your slides up here. I know everybody, we're running a little bit behind, but there's so many good topics here. It's hard to cut people off. Hesham, you want to try? Oh, perfect. Everything looks great. So we're going to let you take it over, and hopefully we'll have a couple of minutes to chat at the end. Go for it.
Sure. Thank you very much for having me to be with the great leaders, innovators, researchers, and friends. Good morning, good afternoon. So it's very difficult to talk about just the peripheral nerve stimulation just in a short time, like 10-15 minutes. My name is Hesham, I'm professor of anesthesia at Case Western. I work at Metro Health Hospital. And I will try to, in short, give you an idea about the history and the current situation and the future of peripheral nerve stimulation. This is my disclosure, and I will discuss some of the technologies that I have some conflict with, but no off-label investigational use of any of those products. So the history of peripheral nerve stimulation is go back a long time ago. And the first documented peripheral nerve stimulation was the old Egyptians. There is a lot of documentation more than 4,000 or 5,000 years ago, documented that the old Egyptians used the peripheral nerve stimulation form in a form of a catfish, a Nile catfish, that they use it and put it in the part of the body to help the pain. So this is kind of the first description. Then after this, by around 3,000 years, the Greek and the Roman also documented the use of peripheral nerve stimulation. So this is kind of the oldest way of managing pain in history. And then in the first description in the modern history of the peripheral nerve stimulation come to the 1962 to 1967 by using the stimulators directly over the nerves in the trigeminal neuralgia. And it's kind of important to know that kind of the earliest evidence in the facial pain, and even with later when we discuss the percutaneous approaches, also with the facial pain, still underutilized for many reasons. But this was kind of the first description, and even the description was the physician that they did this apply for themselves actually. And then historically, the peripheral nerve stimulation progressed, but it was mainly done by surgeon, by open exposure and surgical dissection. They visualize the nerve and they place the leads around the nerve surgically. This definitely affect the access of this technology and also led to a complication like a development of adhesions, fibrosis, and more nerve injury, and they're trying to do some modification by putting facial grafts around the nerve. Still the adoption and the complication rate was high. So this kind of give you an idea how progression is the peripheral nerve stimulation from 62, as I mentioned, 67, and then the first description of a percutaneous approach of the peripheral nerve stimulation, which will be fit more a pain physician and regional anesthesiologist, just insert those leads percutaneously in 1999. But it still take time, 10 or 20 years, till we get real FDA approval, because during those 20 years, most of the procedurists was using leads that was not designed for a peripheral nerve stimulation, that was designed for spinal cord stimulation with the big battery and different design of the leads. They put it peripherally, which lead to, as you expect, to complications. But then many companies and many technologies advanced, and we have a specific leads only for peripheral nerve stimulation, and lead to many adoption of many societies of the technologies. Important to distinguish many definitions when you read about these technologies, what we talking about, what we interested in, what it's have the evidence, it's a direct peripheral nerve stimulation. What I mean by that, you identify one nerve as the pain generator, and you have an imaging technology that allow you to localize this nerve, and you put the wire or the leads close to that nerve to stimulate this nerve. So I have a direct one nerve or two nerves, and you're directly putting the leads around it. Peripheral nerve field stimulation, you putting the wires or the leads at the area of the pain. Transcutaneous electric nerve stimulation with the tense unit, it's just the skin, stimulate the skin receptors. There is other also new technology, you may hear about it, like a static magnetic field and magnetic peripheral nerve stimulation. So it still provide an electrical field around the nerve externally, but by applying a magnetic field. So this is also a different technology using a different modalities. Very important to see the lead design. So mainly in the market now, there is a two lead designs. The classic multiple contacts leads, which is the same leads structure as in the spinal cord stimulator. It allow a complex stimulation, a bipolar and a cathode configuration. As you see in the image in the left side, this is the conventional BNS, which you have to put it closer to the nerve, and it have some advantages definitely, but because it allow you have a complex programming, and also it's a permanent implant, but have some limitation, because as you increase the power and you have a limited number of the A, alpha, and beta fibers to be activated, and it lead to activation of a non-painful nerve fibers, you can say that. The other type of lead design is the monopolar. It's just simply one contact. It creates a large area of stimulation, which allows to put this lead a little bit far from the nerve, and this allowed kind of selectively to activate a larger number or a larger proportion of A alpha and beta fibers. There's a lot of details we can talk about, but because of the limited time, I want to give all the audience just a sense about the design and different ways of stimulation. The monopolar that I mentioned, it creates a big area of energy. So you can put it parallel to the nerve, you can put it perpendicular to the nerve. This relationship is not that important. And also putting the lead remotely from the nerve give you some safety option here. The other classical bipolar leads, you have to put it close to the nerve. And to increase the number of contacts that stimulate the nerve, it is better or advisable to have a parallel relationship between your lead and the nerve. You can still put it parallel, but maybe this will give you a less number of contacts around the nerve. The mechanism of action is a complex, have a central mechanism and peripheral mechanism. The central mechanism inhibits the signals from the dorsal horn, wide dynamic range neurons. The peripheral mechanism, it disrupts the nociceptive afferent and alter the local environment and a lot of inflammatory mediators. Again, I'm sorry, I cannot go through all the details about especially the mechanism of action. The waveform is also critical. When you apply those technologies, you want to know what type of frequency that you aim to deliver to the nerve. Is it low frequency? Usually the low frequency range less than 20, which will give you a motor stimulation. Usually the thinking that we want to avoid the motor stimulation, but actually maybe not. And there's a lot of interest now in actually providing a motor stimulation to help the pain, which for example, hemiplegic shoulder, low back pain, it's the big target. And also now for a knee pain, doing a motor stimulation for the quadriceps muscle, for example, can lead to a pain relief and also indirectly definitely rehabilitation role. The mid-range, which is the majority of the stimulation, which is 20 to 100 hertz. And then also recently is a lot of interest in the high frequency and ultra high frequency. The ultra high frequency, which is very, very high frequency, more than 500 hertz, which is still investigational, it actually provides a nerve block. So it simulates the local anesthetic that we inject around the nerve but by delivery of a very high frequency. And then the advanced programming, which can combine both two and different ways of delivering the shape of the waveform to the nerve. There is two big category, the temporary or the short-term peripheral nerve stimulation, which is FDA approved for 60 days and started using in acute pain actually over like around a decade ago. But now they are using it more in the chronic pain ward, but definitely have a big role in use in acute pain situation, but in a little bit limited role. This is a temporary device, they put only for 60 days, and it could have, it's the structure, it's a small coil. And this coil structure allow fibrotic ingrowth or less risk of infection because you're going to leave it for 60 days, externalize it. There's no internal pulse generator. You connect it to an external pulse generator. But the nature of the coil decreases the risk of infection and also not only that, the risk of migration because it moves with the tissues around it. But this is a temporary device only used for 60 days. There's some evidence showed it even after the 60 days therapy, it still allow some pain relief after removal of the lead. So it can use being acute and subacute pain. It have a great role in chronic pain. The permanent implantation system, which are like spinal cord stimulator, usually you go with a trial. I mean, you put these wires for the patient or the leads for a week. The patient tried. If he had a good response, you implant it by a minor surgical procedure. There's many systems, and the systems now, as I mentioned, not the same as the spinal cord stimulator, and great advances in the technology of transfer the energy from externally to internally. So those devices does not have a battery. It's just a simple wire you insert it close to the nerve, and the patient have to use an external device that deliver the energy through the skin, through the tissue, to the simply the lead and lead to the action. Those are the available systems that available. The reactivate one is the one with the battery. So it have internal battery and it's only used for back pain. Those are different designs of the external wearable that deliver the energy to the lead. And very important with the patient selection that you are doing some sort of selective nerve targeting. Which nerve is important? One nerve or two nerve? Can the patient reach this area? Because the patient will put his hand or can reach out to this area to externally put the device that will deliver the energy. Because again, those devices, the majority of them does not have a battery inside. It's just the wire and the patient have to use an external device. Patient for the permanent implantation have to have an MRI, so you have to have a system that MRI compatible. And the kind of the important question, especially when we have the option of temporary devices and we have the option of permanent implantation devices, which one do you use? So this is kind of a general guidelines. If the patient have relatively 6 months of a pain, relatively acute and subacute stage, you're going to think about doing nerve blocks, catheters, maybe radiofrequency ablation. When the pain is 6 months or the patient have chronic pain already going for a surgery, you will think about the temporary 60-day option. But generally, when the pain is more than a year, multi-year history of pain, usually those patients require a permanent implantation. Just a general guidelines, there is no strong evidence for those recommendations. The techniques of insertion of peripheral nerve stimulation, you can use the ultrasound, definitely, and it's difficult to be good in peripheral nerve stimulation and establish really a good experience and good practice with the peripheral nerve stimulation without ultrasound experience. Some nerve targets, the use of ultrasound is critical. You cannot do only fluoroscopy, like for example, the brachial plexus or the femoral. Some targets are very good with the fluoroscopy. For example, the genicular knee and the cervical medial nerve branches. Only X-ray is a decent option to use them. Many strategists, some will advocate to use a nerve block before the stimulation. It's mainly to isolate the nerve target, not to expect or prognose, to have a prognostic ability for the response for the stimulation. Because when you do a nerve block, you block the sodium conduction. When you do a nerve stimulation, you actually improve the action potential. So the mechanism of action between doing a nerve block and stimulation is kind of opposite. So there is no prognostic value of doing a nerve block and expect the result from the stimulation. Sometimes during the procedure, you test motor, you test sensory stimulation. Sometimes you want a motor stimulation, the trajectory of the needle using ultrasound and X-ray together. Important. Which system you're going to use. Some system, as I mentioned, the permanent implantation, you want to have more of a parallel relationship with the nerve. Very important, anchoring. Those leads need to be anchored to the tissues. Different designs of the lead that help anchoring and make the lead stay were around the nerve target. For example, the 60-day therapy have a small spring coil, so this will allow the movement and anchor to the tissues. The other permanent implantation, as you see in the right upper corner, it have tines, and those tines are proximal to the contact. So you have 4 contacts, and the proximity for the contact is those 3 tines that hook to the tissue and help anchor it. Other system, for example, for the back pain, because back pain, especially the back area, is a lot of movement and you need back and forth movement. So those wires have tines in both ends of the contacts, proximally and distally. So this allows back and forth movement so the lead stay in place. The level of evidence is a lot of evidence. Some nerve targets have a high level of evidence, level 1. We cannot have like mentioned the whole literature in the review article, but you see a surge and increase exponentially in the number of the publication in the peripheral nerve stimulation field. Some areas they have a level 1 evidence, for example, the post-stroke shoulder and the occipital stimulation. And as you see in the bottom of the schedule, he level 1 with the also post-operative pain and post-amputation pain. So using an acute and subacute pain, it have a level 1 evidence according to many review articles. One special about the back, this system that's available for the back muscle stimulation, it's a peripheral nerve stimulation. We put it around the median nerve branch, which is closer to the area of the erectorospinal muscle. It stimulates the multifidus muscle, which is the small muscle medial to the erectorospinal muscle, but also can stimulate the erectorospinal muscle. And it have a battery. So there is no external, they use external, but they have a battery inside and have a very good evidence. This is also a use of a peripheral nerve stimulation. Be comfortable with ultrasound and have experience with regional anesthesia. That will encourage my trainee. It will open the main nerve targets. Many nerve targets see the next 2 slides before I close are from the regional anesthesia. For example, the costoclavicular approach for the infraclavicular bricks. It's a good place for a peripheral nerve stimulation implantation. Make the lead secure, cover the whole upper extremity below the shoulder, and also putting the leads close to the cervical erectorospinal muscle. It's very useful in many indications. Also a craniofacial indication, which now approved by the FDA, combining X-ray ultrasound for the SPG and other terminal branches in the head. It's also useful. Occipital nerve, it's a great target with a parallel approach. Also, it's very useful to have an ultrasound skill to allow you to localize the nerve better. For the thoracic pain, for the thoracic neuralgia, also putting the leads near the DRG or near the thoracic paravertebral space. Also, it's a very good target, which again, the experience from the regional anesthesia side, experience from the ultrasound, it's a great to have to better localize those. There was interest definitely and still interest in the facial plane blocks and a lot of anatomy of the facial planes. Those facial planes have nerves. Using ultrasound also to define those facial plane, but not injecting medication, putting leads in those facial layers that now we are more knowledgeable about them. It's a great target for many location and many nerve areas. And even for a non-pain indication, for example, the vagus nerve stimulation, there's also a lot of interest, a lot of use in this, and using ultrasound to localize the vagus nerve in this area is also important. It's an area of a great research that also I'm working with my team in. So in conclusion, in short, and there's a lot of information definitely there, but it just to give you a great idea, it offers a significant potential to address very complex peripheral neuropathic pain in acute side, subacute side, and chronic pain. Successful implantation require technical challenges, but also understanding ultrasound, X-ray, combining both together and using the right system for the right patient. Consider many factors, and there is a lot of advanced technological in the wireless stimulator and become more compact, smaller, less invasive, very or not very, but kind of easier for a proceduralist, that a non-surgeon like us, to implant, and a lot of also programming capabilities and sensing capabilities. So the leads now can sense and the sense the action potential and act to it. So it's a lot of advances. So I thank you very much, and hopefully we can have questions. I'm happy to answer or answer any email. Thank you very much, everybody.
Thank you, Hesham. Obviously, another big topic. We're just touching barely the tip of the iceberg on peripheral nerve stimulation, and your passion for this technology and the therapeutic value of it is very obvious. For the sake of time, I think we may delay the questions, but I do want to tease people that, that's what these conferences and stuff that we have both in America and Europe. Oh, we lost Hesham there. That these conferences that we have in Europe and America, this is where the opportunity to have these conversations and discussions really shines. And oh, there he is. Okay, great. And so we just want to thank you for kind of giving people an introduction to PNS and what the possibilities are, and the fact that the story's not over.
Thank you, Reggie. Yeah, thank you for having me. Just scratching the surface, and I see that the interest is very up from all aspects.
Yeah.
More advanced AI also it have a role. Ultrasound technologies, combining ultrasound, X-ray, and the devices themselves became smaller, less invasive. The surgical skills that you need to implant them, it's getting easier and easier. So this allowed a non-surgeon to apply those modalities. But I would say the main obstacle for this is approval by insurance to provide this technology to give it to the patients.
Yeah. Well, thank you so much, Hesham, and looking forward to seeing you in person soon again and talking more.
My pleasure. My pleasure.
All right. Have a great day.
You too.